Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association EHA. I am Isabel Olivera, a medical writer at the European Hematology Association. Welcome to this podcast on precision medicine and myeloproliferative neoplasms, MPNs. We have the pleasure to have here with us today Professor Claire Harrison and Professor Jean-Jacques Kiladjian. They are going to discuss among themselves today the current precision medicine approaches to MPNs. First, what is precision medicine? The basic idea of precision medicine is to use large sets of data in order to go deeper into the molecular characteristics of a disease. This allows to better classify patients into groups and to make more accurate predictions about the likely course of the disease or the response to a specific treatment. We will discuss these three aspects today. How does precision medicine helps today in the classification, in the prognosis, and in the treatment of MPNs? Professor Claire Harrison and Professor Jean-Jacques Kiladjian, welcome. Can you please introduce yourselves?
Hello, everyone. I'm Jean-Jacques Kiladjian, hematologist in Saint-Louis Hospital in Paris, France, mainly involved in the management of myeloproliferative neoplasms. And I'm happy today to have this discussion with Professor Claire Harrison. Please, Claire, introduce yourself.
Thank you, Jean-Jacques. My name is Claire Harrison. I'm a professor of hematology working at Guy's and St Thomas's, London, UK. So today, the topic of our discussion is precision medicine in myeloproliferative neoplasms. So to give the listener an introduction to myeloproliferative neoplasms, these are uncommon blood malignancies whose principal manifestation for patients is proliferation of normal blood cells and predisposition to thrombosis, hemorrhage, and then also to transformation to more aggressive forms. So there are three classical so-called Philadelphia negative MPNs. They're defined as that way because they lack the Philadelphia chromosome, so they are not CML. These are essential thrombocythemia, which is characterized by a high platelet count and is probably the most benign of the conditions. Polycythemia vera, characterized by conventionally a raised red cell count, but also often a raised white count and platelet count. Both of these conditions can evolve over time to myelofibrosis, or myelofibrosis can arise de novo. This is a condition characterized by an enlarged spleen, usually ultimately bone marrow failure, some predisposition to thrombosis, constitutional symptoms such as weight loss, fevers, night sweats, and a high risk of evolution to acute myeloid leukemia. Both PV and ET, as I mentioned, can evolve to myelofibrosis, but they can also evolve to acute myeloid leukemia, some of which is treatment related, but some of which can occur, as we've learned from the Swedish Cancer Registry, in patients who haven't received any treatment at all. So it's an innate tendency of the disease. Now, Jean-Jacques, I'm going to hand over to you to discuss precision medicine in the context of MPNs, because I think they are quite a good poster child for this topic.
Yes, absolutely. Thank you for the very nice introduction on these three main classical diseases. So the basic idea of precision medicine is to better classify patients and to more accurately predict the outcome of these patients by using a large data set of information. And what has changed in this disease now about 20 years ago is the discovery of some recurrent mutations in a series of genes. There are three so-called driver genes, meaning that when you have a mutation in one of these three genes, this is sufficient to cause the disease. And these are, as you know, obviously the JAK2 V617F mutation, which is the most frequent, followed by calreticulin mutation, CALR mutations, and MPL mutations, which is indeed the receptor of the thrombopoietin. So with these three main driver mutations, the classification of these diseases, the diagnosis at least of these diseases has been largely simplified. As you know, JAK2 mutation can be found across the three diseases, PET, PV, and myelofibrosis. In contrast, CALR and MPL mutations are usually found only in diseases involving an increase in platelets, meaning essential thrombocythemia and primary or secondary myelofibrosis. In addition to these molecular markers, we still need the bone marrow biopsy. I think this is included in all the classifications, including the WHO and the international consensus classification. In ET, for example, it may distinguish ET from another entity called prefibrotic myelofibrosis that present like ET, usually with elevated platelets only, but with slight differences, including, for example, slight splenomegaly, lower hemoglobin, higher leukocyte count. And indeed, the evolution of this prefibrotic form of myelofibrosis is worse than through ET. So bone marrow biopsy only can distinguish these two diseases. For myelofibrosis, obviously, bone marrow biopsy is mandatory to show the fibrosis in the bone marrow. And for PV, it's not always necessary, but usually it can be useful because you know that some forms of polycythemia vera may have a slight increase in fibrosis at baseline, at time of diagnosis, and then the risk of transformation to myelofibrosis is higher for these patients. On top of this, we have now NGS data. We have a lot of additional genes which can be mutated in these diseases. Some of them are bad because they worsen the prognosis of these patients, increase the risk of transformation to fibrosis or to acute leukemia, or may also increase the risk of developing vascular events. So NGS data is not available everywhere for every patient, so it depends on the access, but I think in the near future, it will be very important for all the three MPNs to have this information to better classify and assess the risk of evolution of these patients. And also, of course, this will help us to tailor the treatment, and precision medicine also includes precision treatment for these patients. So Claire, what are the news in these diseases?
Yes, absolutely. So since the description of the JAK2 mutation, of course, there's been a lot of excitement about our ability to target this mutation therapeutically. It's important for our listeners to understand that this is a mutation which does not generate a novel oncogene. It is really constitutive activation of a normal protein. And so it is not possible to switch off this protein. And so swiftly after the description of the JAK2 mutation, we understood that we would have to target this in a different way. And then came the description of JAK1 and JAK2 inhibitors inhibiting the downstream effects of actually all of the common driver mutations in MPNs. So we have the first-in-class JAK inhibitor, ruxolitinib, and now a series of other compounds, most recently just in January 2024 with the approval of the third JAK inhibitor, Omjara momelotinib. These drugs, however, do not precisely target the mutation, as I've mentioned, and they do have limitations. We are also able to predict to some extent which patients may or may not respond so well to these medications, which are generally used for patients with myelofibrosis, but also increasingly patients with polycythemia vera. In the context of polycythemia vera, actually, Jean-Jacques, you have really moved this field forward with the description of the effect of interferon in affecting the molecular clone and reducing the burden of number of mutated cells, if you like, or the JAK2 variant allele frequency, which we've recently been able to correlate with better outcomes for patients. This is a much more modest effect than we see again with CML, but nonetheless recently in a study actually assessing also the effect of the JAK inhibitors in this context, which is present but much milder than interferon. we've seen that reducing the VAF by 50% can lead, in at least one study, to important benefits such as prolonged survival for our patients. How we integrate that into standard care is going to be a challenge for us in the future. Finally, and I want to leave our listeners with an exciting note, we are currently in the process of actively testing in phase 1 trials inhibitors specifically targeting the calreticulin mutation, since this is expressed on the surface of hematopoietic cells. So there are antibody strategies and bispecific antibody strategies, as well as vaccination strategies looking at this in this field, and we should expect some exciting data to come this year. Any closing comments from you, Jean-Jacques?
Yes, I think MPNs are really a field really perfect for precision medicine and individualized medicine, because indeed, although we showed that these diseases have clear definition for each of them, however, they are very heterogeneous in terms of clinical needs. Some patients suffer of nothing, others have very huge symptom burden. In terms of molecular landscape, many mutations can interact and change completely the disease presentation and evolution. So we need to go deep in the classification and prognostication of these patients to assess their risk and provide the best treatment. And very exciting news are coming, as you mentioned. In fact, with all these new options, therapeutic options that you mentioned, Claire, I think we have to better assess the subtype of the disease, the molecular findings, to have the opportunity to choose the best therapy for our patients. Because now we have many options. As you mentioned, a few years ago, we only had a couple of drugs for treating those patients. And in particular, in the field of myelofibrosis, we have now many options. And of course, all of them are not suitable for all patients, but we have now first-line, second-line treatments, third-line treatments that were not available a few years ago, and also treatments that target the main need of our patients. For example, targeting splenomegaly when it's the major problem for our patients, now targeting anemia for patients with myelofibrosis, etc. So I think we are in an exciting time for these diseases. Everything is not completely clear yet, but we have many options, and this will help our patients to have better outcomes. Thank you very much, Claire.
Thank you, Jean-Jacques, and to our listeners, thank you for your attention.
So, thank you very much for this insightful conversation. Special thanks to both Professor Harrison and Professor Kiladjian for generously sharing your expertise, and thank you all for tuning in and listening.